All right. Hello, everybody. Melissa, it's all yours for the pledge.
Hi, everybody. And I'm just going to do the pledge because no one wants to ever do it. So let's do this thing. Ready? Begin. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. All right. Thank you all for coming today to the March 14th Fortuna Chamber Luncheon, not luncheon meeting Zoom thingy. Today, we would like to introduce our new guest. We have Kelly Johnson, and let's see, what's
Jack Breazeal.
Jeff Breazeal. That's right.
Jack.
Yeah,
Yes.
from the DHHS.
And what does that stand for?
Health. Department of Health and Human Services.
Yay.
Do I have any other questions that I'm getting thrown at me without me knowing about?
What's the weather in Furman? No, I'm just kidding. Go ahead.
Sunny today with light clouds in the sky. So do we have any new members with us that would like to introduce themselves? Michelle's here.
Hi, Michelle.
We got this Ben guy from the Lost Coast Communications. Emily, all right. Well, anybody got any announcements? Nobody new?
Well, yeah, let me do mine and then we're going to kick it over to Ray. Ray's going to tell us about the Kiwanis Club. So, all right. So, let's see. Thursday, is it Thursday? No, sorry. Wednesday, March 23rd at 10 a.m. is a groundbreaking ceremony for the Lutheran Home for the Aging 8-unit complex that's going up on Smith Lane. Our Grow with Google webinar is next Tuesday, March 22nd at noon. There are still spots available for this training on how to optimize your website to attract more customers. You can find the event on our calendar of events at fortunachamber.com with the link to sign up. The Chamber Board of Directors has updated the Chamber bylaws. I put that out in the email newsletter this morning. If you did not get that email, you can send me a message and I will send you a copy of the changes and the current and proposed new bylaws. And then when we are back in person, we will have the membership ratify the bylaws at that meeting sometime in May. As we were talking before we were recording, Man of La Mancha is coming to the Ferndale Repertory Theater. It starts this Thursday, the 17th, and will run through April 10th. You can get tickets at ferndaleRep.org. And then finally, we have a new member, Homegrown. They are a new nonprofit that helps transition-aged youth that are leaving the foster care system attain stable temporary housing in homes of community members. So if you have a spare bedroom or extra space in your house and you would like more information, they are having an informational session on the 21st, next Monday, from 6 to 6:30 p.m. on Zoom. You can email info@homegrownhosthomes.org for the link. And we also have that up on our calendar of events at fortunachamber.com. And with that, I will turn it back to Melissa.
And I'd like to welcome, Ray. Ray.
Can I ask a
Let me
question
unmute.
really quick?
There we go.
Renee, when was the ribbon cutting? I'm sorry for interrupting.
Oh, we don't have a ribbon cutting.
Groundbreaking.
Groundbreaking, March 23rd. Yeah. Thanks. Yeah.
Okay.
10 a.m. 10 a.m. on the 23rd. Yeah,
Okay.
it'll be outside on Smith Lane.
Okay, thank you.
Yeah.
I'm sorry.
Okay. No, you're good.
She muted me, Ray. I
did. The screen jumbled and I was trying to mute myself. I'm sorry.
This
Go ahead.
grand announcement to introduce the Kiwanis Club and you muted me. All right,
I'm
Ray.
sorry. Go ahead.
Let's
Review.
hear what Kiwanis has got going on.
I just got scooped. Okay, yeah, the Kiwanis Club has a couple of events coming up, as we always do. They're just around the corner. Not this coming Thursday, but a week from this Thursday, there's going to be a open house community event over at Eel River Brewery. It's on Thursday, the 24th. It's from 5:30 to 6:30, and it is a kind of a meet and greet, find out who the Kiwanis are, get to know us, and find out how we can better meet the needs of the community. There will be light refreshment served, so after work, stop by and have a brew and eat some I don't know, chicken wings or whatever we happen to have out on the table. We haven't decided that yet. So everybody's welcome. It's open to the public. Tell your friends. We'd like to really communicate, have as many people from the community there as possible. There's a second item, and that has to do with our annual spaghetti feed. Every year we have a spaghetti feed to raise money for the local 4-H kids. And this year is no different. It will be on April 3rd. And the time is from 4 to 8 p.m. at the Fortunato Veterans Hall. It is, let's see, what is it? $7, $10 donation. It's great dinner. You get spaghetti. Let's see, you get garlic bread. What else? Okay, well, it's a full salad. It's a full dinner, and all the proceeds go back to the 4-H kids. Both of these items, the open house and the spaghetti feed, is on the chamber website. So if you want to look it up for specific information, you can always go back to the date and the time and all of that. Thank you much.
Ray.
Hey, Ray. Bob Judavine, welcome to the party.
Sorry, I'm late. I was blasting into the wrong Zoom meeting and nobody told me I wasn't supposed to be there. It was like a super secret thing.
Okay, are we city counciling tonight, or do we have the night off?
Night off. It'll be next week. I'm sure Merritt's working hard on the
Okay.
agenda. Board of Supervisors tomorrow. Anything?
Michelle, got anything?
Happening?
So we are doing, as far as tourism, we're doing some reviews of the airports, which is going to be really good, and reviewing the hangars, looking at the hangar. Well, it's on the agenda, so as long as it's on consent, so as long as it gets approved. And then also installation of a new fuel, airplane fuel at Murray Field, which has been quite controversial. So that's really good. And then the one item, we're going to have a discussion on the CARES Act monies that we'll be utilizing for aviation also. So that's, it pertains to everybody. It's all the airports, so including the one in Fortuna. So that's great. And then we have a couple closed item sessions, which are based around the same discussion we've been having for a long time. So that's about it.
Well, I'll throw it out there. So I know 2 meetings ago, some allegations were made, and I thought there was another meeting or another presentation or something that was supposed to happen.
So since you asked, I'll comment. Yes, there was a written report that was supposed to be coming tomorrow from the AC's office. However, it didn't get routed, and we inquired many times last week to have it put into the Legistar, and so far we have nothing. So that's as much as I get to know, as much as everybody else. So we're still waiting, and haven't gotten communication on when that will come forward.
Yeah, I looked through the agenda, so I saw the presentation
Yeah.
for the airport, which is great, and it made me think of it, and I didn't see anything. So now
Yeah, the department
I'd
heads, like you, Renee, the department heads, especially the ones that were accused, are patiently waiting for that.
Okay, well, thank you for that update. And also, there's a Measure E meeting, I believe, Merritt, if you're listening. Can you let us know, is that still by Zoom, or are they back to in person at Chambers? If he's listening. Ooh, he is listening.
Sorry,
There
this one's on Zoom. One of our board members couldn't attend, so the next one will be in person after this one.
Okay, great. And that's where they're going to make some recommendations on how to spend the money, yeah?
No, not at this one. This one, they're
No.
just going to be accepting staff proposals for projects. And so at the last meeting, they received the public's list. And so not this meeting, but the following meeting, they'll reconcile the two. Staff will give them a recommendation. They'll be making decisions.
Gotcha. Okay, great. Thank you.
Yep.
And with that, I think we're done. All right. Well, today, let's welcome our guests, Kelly and Jack from DHHS. Welcome, you guys. Take it away.
Hi, thanks for having us today. Really appreciate being here. I thought I would start off just kind of like this sort of broader overview of behavioral health and how we are organized a little bit, then talk about funding a tiny bit, and then talk about services then that we offer for the community. As you mentioned earlier, we really are representatives from Department of Health and Human Services, but we are within the behavioral health branch, and the Department of Health and Human Services is the bigger agencies that incorporates public health and social services, and they perform a lot of different functions for the community. So behavioral health is just one of those branches within that larger department. My role with behavioral health is I'm a deputy branch director. So I oversee a variety of different programs within behavioral health. There is one director, and then a behavioral health, and then there's 3 deputies, and then there's program managers as well, and on down. And so the thing I always like to talk about when talking about behavioral health a little bit is how we're funded, right? So, you know, we run a variety of different programs, but a lot of them are funded through Medi-Cal dollars, right? So those are services that we provide to beneficiaries that have Medi-Cal insurance. We do provide services to people maybe with private insurance, so like Blue Shield or Blue Cross, but those are pretty exceptionally rare. So a lot of the times when we talk about these services that we provide, it is, you know, for Medi-Cal beneficiaries, but we do have a lot of services like crisis and things like that that are obviously, doesn't matter what your insurance is, you know, you would get that service. So for behavioral health, we kind of compartmentalize them into 3 ways. We have our crisis services, then we have our sort of traditional outpatient services for adults, and then we have our outpatient services for children. And so within those services, you know, it just depends on what's going on that you would be funneled to that particular service. So specific, I think, to you know, the outlying areas that we have, that, or the non-Eureka area, right? We have a program called Regional Services that I'm in oversee. And that particular service, you know, we have a clinician and a case manager and a substance use disorder counselor that go to those outlying areas. So they will go to out to Garberville, and they'll go to where else do they go? Out to oh boy, I lost it. Sorry. They go to a couple of towns there in southern Humboldt. Yeah.
So the coverage areas that the regional services team covers, which by the way is Measure Z funded, has been since the start of Measure Z. They serve Fortuna South, McKinleyville North, and Willow Creek East to Orleans. And so it's basically everything outside of like the greater Eureka area. So anything north, east, or south.
Right. Thanks, Kelly. And I think that that's, you know, a good point to recognize that those particular services are funded through Measure Z. And so those are not necessarily dependent upon an individual having, you know, Medi-Cal, right? Again, a lot of our folks do have Medi-Cal, but you know, if an individual needed service and didn't have that, or had a private insurance or commercial insurance, that those individuals could get seen by those particular clinicians and substance use disorder counselors. So the other piece that I'll just talk about a little bit, and then I'll let kind of Kelly talk about her part, and she might mention a little bit of this too, but you know, obviously county mental health oversees, behavioral health oversees Sempervirens to the psychiatric hospital that we have here, right? And we certainly can get into specifics about how individuals, you know, get to Sempervirens, but essentially, you know, those individuals in our community that are suffering from a mental health condition and then are also danger to themselves or danger to others or present as gravely disabled, right? That those criteria, they they would be eligible to go to Sempervirens, provided that Sempervirens had a bed, right? One of the things I think that is difficult is we run it that Sempervirens is a 16-bed hospital, but because of staffing and especially nursing shortages, we've really had to run at a very limited capacity there, only 12 beds. And then we have a variety of those beds up there that are taken by individuals who are awaiting long-term care. And so that even shrinks down the capacity that we have. So individuals that do need that level of care, that sort of psychiatric inpatient, a lot of times will be at our local community hospitals awaiting placement in out-of-county psychiatric hospitals. So sometimes that has come up too, where especially during the pandemic with folks in our emergency rooms, and we're waiting for them to go to out-of-county psychiatric facilities. So I'll kind of stop there and let Kelly take over from here in terms of what she does specifically.
Thanks, Jack. Hi all, I'm Kelly Johnson. I'm a senior program manager at DHHS Behavioral Health and Adult Services. And I wear several hats, but the main things I do is I oversee our forensics programs, which means anything to do with law enforcement or the criminal justice system. So I have the jail, behavioral health, probation. We have what's called the Community Corrections Resource Center for people that are being released from prison via AB 109 realignment back to our county. And I have the MIST team, Mobile Intervention and Services team, which is kind of morphed over the years based on our different funding streams. And I also have what's called the Mobile Response Team, which is the team that provides crisis intervention assessments to people that have already been placed on a 5150 hold or are at risk of psychiatric hospitalization. And so I also do what's called crisis intervention team training for law enforcement. It's an annual training for 40 hours for all of our local law enforcement agencies, training them in de-escalation strategies, and really covers quite a bit of behavioral health education to help them identify signs and symptoms of behavioral health disorders, and teaches them tools and how to better intervene to promote safety for officers as well as the people that they're coming into contact with. So I could talk about all of these things in depth all day long, but I want to make good use of time. So I'm wondering if folks have specific things that they're wanting to know, and then maybe I could do like question and answer type thing, or I can just keep talking about those things in more depth. What is your preference?
Sorry, my dog was barking in the background. I didn't want to unmute myself. I would love some more information on, what Jack was saying about people that get into Sempervirens and how that process goes, and, what does a 5150 really mean, and when can that happen? And, sort of the assistance that our local PD could get in dealing with some of the more chronic situations here in town.
Absolutely. So another hat I wear is I do all the 5150 trainings for our staff. And so 5150 is in the Welfare and Institutions Code. It outlines what's called the Lanternman Petrus Short Act, or LPS Act. It dictates all of the laws surrounding involuntary civil commitment for people with psychiatric disorders. It has very strict criteria. What it is, a 5150 is an application for an evaluation for up to 72 hours. It's not a guaranteed 72 hours. It's an application to be evaluated. And then there's a whole legal process that follows when that 72-hour ends. So each county in California follows the W&I, Welfare and Institutions Code, but they have some flexibility in how they interpret the code. So each county's behavioral health director gets to designate who is allowed to write 5150 holds as well as rescind 5150 holds in their county. So every county includes peace officers. So any sworn peace officer in the state of California has the legal right to write 5150s. They do receive some training in the police academy, about 16 hours of behavioral health training. It's not specific to 5150s. It covers everything that you could ever want to know about behavioral health orders condensed into 16 hours. It's really not very much training. And then we have the 40-hour crisis intervention team training, which also goes over what 5150s are, but that's a voluntary training. We have trained about 500 individuals in our county in CIT since we started in 2007. Fortuna does send people to that training. So the other people that can write 5150 holds in our county include emergency room physicians, but they have to take a training and a test to be designated. In the past, they were not required to take a training or a test. Any ED physician could write a hold. We implemented the training and testing about 2 years ago, which is consistent with how other counties do it. I also help with coordinating those trainings. We have an online training for the ED physicians that takes about 1 hour. There has been some resistance from local ED physicians to take that training for a variety of reasons. You know, I'm a doctor, I shouldn't have to take a training or a test, or I've been writing them for 15 or 20 years. Why do you want me to have a training now? Yada, yada, those kinds of things. And then within DHHS behavioral health, any licensed staff can also take the training. That includes licensed nurses, licensed behavioral health clinicians, so like licensed clinical social workers, licensed marriage and family therapists, and then of course psychiatrists and nurse practitioners. We are looking at possibly changing the requirement to not require a license, meaning if you are a master's level clinician, you have a master's degree in social work or counseling psychology, if you take the training and test, we may shift to allow that. And that's really due to staffing issues. I've had 3 vacant clinician positions for the mobile response team for about 3 years, and I've been unable to fill them. And with the pandemic, everything has shifted. So everybody that was placed on a 5150 hold by law enforcement previously were brought directly to our behavioral health main building where Sempervirens and our crisis stabilization unit are. With the COVID mitigation strategies that were put into place, everybody needed to be routed to the hospital emergency departments. I'm sure you've been hearing about this. There's lots of concerns about how this is impacting our hospitals. My team, the mobile response team, is responsible for providing those 5150 assessments in the emergency departments to determine who should go to the psychiatric hospital or who's meeting criteria for that. Just because somebody's placed on a 5150 hold doesn't mean that they will be psychiatrically hospitalized for a number of reasons. We don't want to take people's rights away unnecessarily. The criteria is very specific. I'll go over that in detail in just one moment. And also there's a shortage of beds, not just in Humboldt County, across the state, across the country. This is a major problem. We're lucky that we have a psychiatric health facility. None of our neighboring counties have them. The nearest other psychiatric health facilities are in Shasta County in Redding and south in Santa Rosa. So we, as much as people complain about our lack of services here, we actually are doing a lot better than Mendocino, Del Norte, Trinity, Siskiyou, like any of our surrounding counties don't have that at all. And they've always had people on 5150s go to their emergency departments, and then they work on finding out of county placements. COVID's done a number, as you know, on everything. So anytime a hospital has a COVID outbreak, they stop accepting referrals. Anytime there's fires or bad weather, transport can't get to the hospitals that we contract with. And so there's a number of reasons why people get kind of stuck in the EDs. What we've learned through the pandemic is that we end up rescinding 30 to 40% of the holds written by law enforcement. What that means is those weren't appropriate 5150s in the first place, or maybe the person's crisis resolved by the time we assess the individual. We typically try to assess a person within 24 hours of receiving the packet. So when they get to the ED, the hospital staff will fax us a packet with the hold and any pertinent information we need. And then we have a clinician who's been doing the assessments remotely through video. And the reason why we're doing that originally started with safety for COVID, but then it turned into a capacity issue because now we're seeing 2 to 3 times as many people as we did pre-pandemic because everybody's being routed to the emergency departments. So I have one clinician a day. They can do 3 to 5 assessments in a day, depending on how complicated the cases are. So if we have 10 people stacked up in the EDs, we have to triage which ones need to be assessed first. I could go into detail about the triage process, but it's really nuanced and complicated. So unless there's specific questions, I'm going to skip that part. So for 5150 criteria, first and foremost, it has to be due to a documented or suspected mental health disorder. That's a specific diagnosis such as bipolar disorder, schizophrenia, major depressive disorder, something that's a mental illness, not substance use, not a developmental disability, not criminal behavior, not a traumatic brain injury, not dementia, not just being obstinate and not wanting to access services. They have to have a mental health disorder, and due to that mental health disorder, meet one of the 3 criteria. First, danger to self. That means they're either actively suicidal with a plan and access to means and intent to follow through with that plan, or they're so mentally ill that they just are unable to keep themselves safe. So let's say they are in the midst of an acute manic episode due to bipolar disorder, and they believe that they are playing the game Frogger in real life and they're weaving in and out of traffic. That could be danger to self due to their mental disorder. That's a little bit harder to prove. And then there's danger to others. So due to a mental disorder, they have to be have a plan and means and intent to harm another person, either willfully or similarly like the Frogger thing, like that could be danger to others, right? Because they're causing disruption to traffic that could cause somebody to get into a car accident. There's other types of examples where that might apply. And then the third is grave disability, which is the hardest to prove. This is due to a mental disorder. They have to be unable to care for themselves with food, clothing, or shelter. That doesn't mean that just because they're homeless and they're eating out of a trash can and their clothes are tattered, that they would meet criteria. It has to be something along the lines of they are experiencing psychosis and they have food available to them, but they won't eat it because they believe it's poisoned. Or they could go to a shelter, such as the rescue mission, but they refuse to stay there because there's demons in the walls and they don't feel safe there. If they choose not to go to a shelter because they prefer to camp or sleep on the streets, or they don't want to follow the rules, that wouldn't count as grave disability. The same with the food. You don't like the food at the soup kitchen, so you choose to panhandle to buy whatever food you want. That, that's sort of the difference there. And again, it's very nuanced. It's dependent on the judgment of the person assessing for 5150 criteria. And that's oftentimes the holds that we get written by law enforcement really aren't able to justify how the behavior's linked to the mental health disorder. So that's the criteria in a nutshell, the overview of how, let me tell you a little bit more about what happens if they're in the ED and they're on a 5150. So the clinicians will assess to determine appropriateness of the hold, essentially. So they can either uphold the 5150 or they can rescind the 5150. If they rescind the 5150, we have a team, including a case manager and peer coaches, which are people with lived experience in the behavioral health system of care. They provide aftercare support to those individuals to prevent future crises. And the goal is to get them linked to ongoing outpatient services that are voluntary. That's the key word. And the trick is that people have to be willing to follow through with care unless they're meeting that 5150 criteria to be involuntarily treated. If the hold is upheld, if they are a Humboldt County Medi-Cal beneficiary, they will be considered for acceptance to sempervirens or crisis stabilization unit based on capacity. So if there's a bed, they will be put in the queue for admission. The doctor will review the packet, decide whether or not they can accept that patient to our unit. If they are not, they will start a bed search for out-of-county placement. And that goes for folks with private insurance as well. So depending on which hospital it is, we have 4 hospitals in our county. The one we work with the most is St. Joseph Hospital. And then obviously Redwood and Fortuna and Mad River and Arcata are kind of tied in terms of numbers of people that we see. And then very rarely we'll get a referral from Gerald Phelps. They're the least likely to have folks on 5150s for some reason, or for lots of reasons, but I digress. So St. Joe's and Redwood has a team built into the hospital, the BART team, Behavioral Assessment Response Team. So they have a nurse and a case manager, and they typically do the bed searches for Redwood and St. Joe's. And they work in tandem with our team around whatever's needed to help get people placed. With Mad River Community Hospital, our staff and our crisis stabilization unit does the bed searches for them. So what that means is we fax a packet with all of the documentation from the hospital, the documentation from our team, including the 5150, and they fax it out to the different hospitals that accept that person's insurance. And then depending on where they get placed, it's up to the doctor on that unit to determine if they're still meeting criteria. And each step of the process involves a lot of legal stuff. And so after the first 72 hours, it goes into what's called a 5250. They have what's called a probable cause hearing, where there's a hearing officer, which acts as like a judge. And then there's a sort of like in a regular court, there's like the defense and then the prosecutor, that's not the right term, but the nursing staff in the facility will provide the evidence that the person still needs to be hospitalized. And then there's what's called a patient's rights advocate that serves as sort of like defense counsel and advocates on the client's behalf. And then the hearing officer says, you gotta discharge this person. And so then the doctor has no control over that. They must discharge the person. And this is one of the biggest complaints I hear is, why did they get discharged so quickly? And why did you just let them go? And so it's tricky. And then the longer that 5250 is only good for 14 days, and then it goes through another whole hearing process. And so it's really tricky to get people in the door and then to keep them inside for treatment. And there's really specific criteria and oversight overseeing that whole process. So I'm going to pause there and see if there's any questions or other things you'd like for me to talk about.
Anybody have any questions? I mean, I have I guess an overarching question is, you know, the average person in town, right? Or PD, like, I mean, how can we help as community members, as business members, as city council representatives, as police officers? How can we come together and solve some of these issues? I know that there's talk of forced treatment at the state level. I don't know how that's going to play out. I know that, you know, it's a multi-level problem. There's the drug addiction, which is separate, and then which came first, the drug addiction or the mental illness, right? And were they self-medicating their mental illness, and now they have completely are completely addicted and unable to take care of themselves, or did it go the other way? So I don't know. I guess I'm just looking for that kind of advice. Like,
Sure.
what can we do to help you or help our police officers, or what? I mean, do we need a larger state hospital? Do we need more drug intervention programs? Do we need transitional housing across the county in towns that maybe don't necessarily want it? I'm just throwing those out as some of the things that have been suggested in the past.
For sure. And I'll just speak from my perspective. I'm sure Jack has some input as well. I will say yes to all of the above. I think, honestly, I've been doing this work for almost 20 years now, and in Humboldt County for 9 years. I've been with the MIST program from day one when we started in January 2015. And what I see is lack of resources. Everything is so dependent on funding streams. And so in general, behavioral health systems are chronically underfunded. And as Jack said, that we have to serve people that have Medi-Cal that want services to be reimbursed for our services. And so we've been lucky with funding such as Measure Z and other types of funding that allow us to have staff that can do outreach. I think that that's hugely important because we can't bill for those services. So we don't get paid to provide that service unless we have a funding stream that allows us to do that. And so I think doing that assertive engagement and outreach, sometimes it can take years to get a person to voluntarily engage in services. So if they're not meeting that 5150 level of care, they need to actually want to get better, unless you go the forced treatment route. I think advocating for sufficient funding for behavioral health programs, also housing, and these specific outreach type services are huge for me. We did just get a grant for 1 year to partner with the sheriff's office and sheriff's jurisdiction to be able to provide those types of services in co-response with the sheriff's office. Again, we have a staffing crisis. So my hope is to be able to fill those 6 positions that we've been allocated funding for. And we have applied for Measure Z funding to include housing that would allow 5 beds for people that are really cycling in and out of the criminal justice system due to their mental health disorder. The goal is to get them into housing to help them stabilize and to get them engaged in services, and then get them into permanent housing so that, they're not just having that revolving door. 5 beds is obviously nothing, but it's better than nothing. So, I mean, it's very little, but I know the county's done a great job in developing more housing, and it's still challenging to be able to get into those housing units. You have to meet the HUD definition of chronic homelessness, which involves a lot of legwork to get all the documentation in order. And so even though we have these housing units, it's still tricky, especially if people are actively using and have an untreated mental health disorder and maybe aren't that excited about following rules or engaging in services.
Or being sober.
Right. Yeah. So go ahead,
So,
Jack.
Yeah, thanks, Kelly. You appreciate you've done a great job of explaining all this and are very knowledgeable. I think the thing that Kelly said that I would really agree for in terms of what you can do is in that advocacy role, right, for increased funding. You mentioned forced treatment, right, and along those lines, though not quite like it sounds, there is a program that we're starting hopefully really soon, by April 1st. I'm hoping to get it up and going, and that's our assisted outpatient treatment program. Right now, this is a pilot program that we're running, which basically says if an individual, after a sufficient amount of outreach and engagement, decides they don't want treatment, but we recognize that they need it, and without it, they're going to end up in sempervirens or in jail, we can petition the court to get that treatment for them, right? So we're running this pilot program, this AOT, and the Board of Supervisors was gracious enough to fund that for us, right? So Otherwise, we would not have, we would have to take from other services we offer in order to fund that one. And we will be reporting back to the Board of Supervisors the outcomes of this program, right? And I think that in many ways, you know, we want it to be successful and be able to advocate for more, right? You know, so this program is funded largely out of the general fund, and we're really excited about it. But, you know, in order to increase our numbers, we're going to need to increase funding in some ways. My hope is that, not that it's all general fund, but that we also receive some savings from reduced admissions to sempervirens, reduced long-term care budgets and things like that. So we'll be looking at how that domino effect occurs with this program. But that is one example of what I think, you know, community members can do in terms of advocating for these programs, advocating for funding, both at the county and the state level, right? We're doing another initiative, a crisis residential program. And what this is this is a 10-bed facility for individuals who are stepping down from sempervirens or in danger of going to sempervirens, where they could stay in a residence for about 30 days and have oversight from staffing and nurses, right? And have access to psychiatry. And so we're funding that program. And if that one's successful, right, we would like to see more of that, right? Because I think that's that gap. You know, one of the things I was thinking about when Kelly was talking too is the folks that go to sempervirens and get better, right? We let them out into the street or wherever they go, right? And they're feeling good, they're better, symptoms are reduced, but then all of those, you know, environmental stressors come back, all of those things, those temptations for drug and alcohol use, right? And all those things, you know, start creeping back into people's lives. And I think a facility like a crisis residential gives them a broader treatment base, right? There's, you know, it's kind of half inpatient, half outpatient. And, you know, hopefully that minimizes some of those things that happen, you know, that lead people to go right back into sempervirens. So all of that stuff, all of those initiatives and programs takes funding, and it takes advocacy that you know, we know these programs work, we just need more of them. You know, so I would sort of second that statement by Kelly about funding. So
Do you guys have an idea of the numbers that you're talking about in Humboldt County of folks that are, you know, truly homeless? And do you have them separated by those that are medicated, unmedicated, and then those that are using and not using?
I don't think we would have numbers like that. We do this thing, we don't, but we participate sort of loosely with this point in time survey that's done in the county, and that kind of tracks the number of homeless in our community. I think a piece of that is probably people that self-disclose mental illness and self-disclose you know, drug addiction, but that would be their, you know, prerogative to do that. You know, but I think that brings up a point too. You know, individuals who suffer from these conditions, especially psychosis, right, like schizophrenia and bipolar. With schizophrenics, right, they don't really recognize that they're ill, right? They think the world around them is, and so you try and do outreach with them, and they're like, you're the government, buddy, you know, and don't want our services. And then people who are bipolar and manic, right? A lot of times that's a very nice place for them to be. You know, they don't want help for that. You know, they enjoy that beyond law enforcement telling them to stop, right? They're really having a good time. And so I think a lot of these conditions are pretty difficult to treat, and, you know, people don't always recognize that they're going through that.
Well, and I think that I've, you know, I don't know if the assisted outpatient, is that Alice's law, or there was some law?
Laura's law, yeah.
Laura's, okay. You know, about that, you know, it's hard to, obviously, to get people into treatment if they don't want it. You know, but then the other thing that came up is sometimes all of this drug abuse potentially damages that part of the brain that, makes the
Right.
decisions on where should I
Yeah.
sleep and should I clean and what should I eat and things like that. And so that's where I think some of this, idea of like forced treatment or the assisted outpatient may be more meaningful, hopefully, for our area, for those folks that, just are dependent at this point on the
Right.
drugs that are helping them
Yeah.
to survive day to day.
I think that there's a lot of factors that have sort of led to this crisis and then this attention on behavioral health, but methamphetamine is on the top of my list in terms of, it has created individuals who otherwise are not, psychotic or, but it has created the symptom presentation in them that's very confounding and difficult to treat. And you got addiction on top of, like you mentioned, obviously these very scary symptoms and debilitating symptoms, right? And so, yeah, it's coming at it from all angles. I think we're very excited about AOT. I know behavioral health, we put in a lot of work to get this going and we're really excited for it. But I also recognize its limitations, right? So we take somebody to court and the judge says, you better, take your medicine and talk to your therapist. But beyond that, right, there's not like, if you don't, there's not really some sanction, right? And so it really is sort of this team effort with the judicial system and clinical, right, to try and help people and convince them to stay on track. And, I'm a believer that it's going to help, but I also recognize some of its limitations too.
Yeah, cautiously optimistic.
Yeah.
Michelle Bushnell, I see your Supervisor Bushnell. I see your hand raised.
Thank you. Michelle's always fine. I just wanted to ask Jack or Kelly a question just for clarification on Laura's law. We currently are in process of putting that together. It's not quite functioning. Is that a true statement?
So yes, my hope is that April 1st, we will have started with, we'll have participants that are enrolled in that program.
Okay, perfect. So that happened quicker than I thought. So that's amazing.
Yeah, a lot of momentum behind that, certainly from Connie and Emmy. So they've really kept that thing moving along. And so, yeah, this week we're going to have an internal meeting here at Behavioral Health, and we're going to identify a couple of folks that we kind of know just internally from Behavioral Health and get those referred to Environmental Alternatives EA, which is the nonprofit that's running this for us. And so get it going.
I'm excited to get the report back, whether it's through Chambers or whether it's helpful. There was a lot of discussion, that we wouldn't reach a good group of people just because they didn't qualify. So as a supervisor, I'm excited to get that report back to see, and then also for our community to see how helpful it ends up being or not. I mean, it's all, it's a toss up.
Well, we've hired kind of one analyst to kind of track this for us, right? And she's been onboarded and working hard already. And we're going to use our new fancy, shiny software, that Tableau, right? That hopefully will give us some good data to look at in an appealing way. And yeah, I think, we're going to look to see if the program is successful, where else can we draw funding from to keep it going, to increase the numbers. 10 isn't a lot, but I think it'll be a good start for us.
Yeah, well, thank you for answering my question. I appreciate it.
Thanks.
And I just wanted to add, it has been proven to be highly successful in other communities. So I feel hopeful and I'm very excited, and I'm the last person to want people to have involuntary treatment. I'm a big believer in engaging people voluntarily, and I know the limits of that. So I think having both things are very important.
I think that, I can speak from the public BOS meeting that documentation of it being successful in other counties is where our BOS board came, was finally convinced that it is something that could be helpful in our county. So Kelly, thank you for that. And I agree that it seems to have it works in other counties. There's no reason it can't work here.
One quick additional comment about that. It reminded me, so with AOT, there is a mechanism by which, I mentioned we're going to get together and do this internal meeting to select a couple of folks. This is sort of our let's get it going process, but really it's a community sort of referral system, right? There are some rules about who can refer, but I think ultimately, if you knew somebody who suffered from a mental illness, right, or you knew somebody that needed help, you could contact those individuals and say, hey, there's this program, right? Go ahead and refer them. So the rules are with it that it is largely like first degree family members, so mother, father, brother, sister, and then other kind of professionals in the community. So law enforcement can do it, or other, private therapists. But I think it's good. It'll be a good program for the community to know about, because there'll be a mechanism by which to refer people to that. So.
Great. Well, that's really good news. And I would expect some calls from Fortuna PD with recommendations. But thank you both. I think it's a conversation that needs to keep happening. And and like you said, it's not a one size fits all. There's got to be multiple layers to solving the issue because it's a multi-layered problem. So thank you both for being here and sharing your information and your experience and wisdom with us. I really appreciate it. And for all of those, the rest of you have a great week. Unless there's any final questions, it seems like everybody's relaxed. Good. Thanks everybody for being here. We'll see you next week. Thanks, Jack. Thanks, Kelly. Bye.